Hello, one and all. Mark Brownstein here. Welcome. Welcome to take two of this Medicare webinar. Had some technical difficulties last time, but we are good and ready to go this time. I'm so excited to be here with all of you. We've got 100 people signed up. And so I know and I can tell that people are more inclined to do webinars these days than seminars. And so I love being in front of all of you, and in a way wish I can be in front of you, because that's where a lot of the questions come from, is hearing other people's questions, and then just getting inspired to ask questions of your own that relate to your situation. So I have my able assistant, Michelle, on this webinar with me. So if anyone has a question of any kind, please don't hesitate to communicate to Michelle. And if there's any follow-up after the webinar, certainly myself or my team will be happy to follow up. As many of you know, some of you who are clients of ours, some of you who have heard me speak before, either live or on a webinar, to me, Medicare is all about education. That's what I do. That's what I love to do. So I also have Jackie Vogel on the line, and she is, for the last 8 months, she's been learning and becoming quite proficient in Medicare as well. And so she is assisting me with a lot of the new opportunities that are coming our way. But my staff is so qualified. We have a staff of 7. We have almost 2,000 clients in 26 states. And so really proud to be able to provide this webinar. Clearly, there's a lot of interest in understanding Medicare. So you can see on the screen that this is 6 out of the 7 people. Jackie's actually not in this picture at this point. But again, please don't hesitate to reach out to Michelle for questions. And again, I hope this is valuable, and I'm going to start up. But one thing I will say before I begin is I just came back from the crazy town of Las Vegas for a 3-day Medicare conference where there was 3,000 people talking about this industry. And I learned so much. And I'm going to share some of what I've learned here in this webinar, but there's really a lot more to share. So what I'm going to do over the next couple of weeks or a month is put together a summary of some sort of things that I believe are important to the average financial planner, CPA, consumer, social worker, case manager, HR person, veteran, who might actually need to understand a little bit about the future of Medicare. It was very exciting to be there. I went to about 13 different sessions, and I learned a lot. I took about 17 pages worth of notes. So I'm really excited to share that knowledge. But in this particular webinar, I'm going to give the basics. And again, if you have any questions, please go ahead and ask Michelle. So again, thank you for being here. So I've built my career in healthcare. I ran a training company out of New Jersey, and I had a team of 32 people. I've trained on healthcare. I've been involved in healthcare really all my career. But I'm also an advisor to many different advisors, whether it be CPAs or financial planners or medical offices or case managers or just the average consumer looking to understand Medicare. That's what I do, and I love speaking about this topic. I was the president of the Financial Planning Association, so I'm very connected to a lot of financial planners and CPAs, and they value the knowledge that I have for their clients. But I've conducted workshops for at least 4,000 seniors and at least 2,000 advisors and healthcare professionals. So I've been asked a lot of questions, and it's changing, but not as much as people think it is. But it is an area that people are often nervous about. I'm the sole independent resource for my local healthcare system. So being independent, I represent 17 insurance companies. I'm absolutely independent and always going to look out after your best interest. That term is called fiduciary. So I'm always going to look out after your best interests. I'm very active in my community. I'm involved in many boards and very proud of that and always like to give back to my community in many ways. So what I'm going to cover here in this time together is navigating Medicare, turning 65 or retiring. What's the history of Medicare? I'll go over that a little bit. There are some decisions that are unique and different for everyone. There are some enrollment periods that people are often talking about. Some people have it right, and some people are concerned and scared, and we'll go over that, which makes, you lead towards penalties and some rules. Again, if you start reading some of the pamphlets and marketing material, it can get very confusing very quick. But at the end of the day, a lot of what is important is your doctors and your medications. So Part D is important, and the doctors are a part of your medical coverage. And the advantage plans and supplemental plans are really the core to the decision. Many of you maybe have a government plan through a teaching organization you've worked for, school district, and you may have company coverage in retirement. But in general, for those folks who don't have the benefit of some of those great plans, the choices are advantage and supplement, and we'll cover that. Dental, 80% of all the people I talk to ask about dental. I've done separate hour-long webinars and seminars just on dental, but I will cover it a little bit. There's dual special needs, which is Medicare and Medicaid, and again, questions in general. So, you can shout from a rooftop all the questions and all the frequently asked questions that come up from Medicare. Part A, when do I do it? When do I need Part B? What happens if I delay? If I'm working for a large company, small company, what are the penalties? What are the copays? And so, these are the kinds of questions we get all the time, and we're really so happy to answer them, but there's confusion. And the general basic confusion is, do I have to go on to Medicare when I turn 65? And again, it depends on the situation. And in the initial assessment that Jackie, I, and others in our company ask is just to understand a little bit more about your personal scenario. Can I defer Medicare Parts A and B? In many cases, the answer is yes, but in many cases, it's beneficial or a cost savings to go on Medicare A and B in a supplement. I'm not ready to retire. Many people in this area work past 65. So what do I need to do at retirement or at 65 so I don't have to worry about anything in the future? Again, the word penalty comes up all the time. Very, very few people that I've ever worked with have had a penalty because they're in touch with us often 3 months before they retire, 3 months before they turn 65, or even 3 months before they move. So healthcare costs are so vitally important to calculate. With the financial planners and the CPAs that I work with, they understand and they're planning for healthcare costs. It's really one of the top concerns, but more and more, so is dental. Yes, running out of money, but healthcare costs are becoming so important. We all know that there are challenges in our healthcare system in America. We all know there's prescription drug issues that are sort of being laid out for us, and some prices are going down and some prices are going up. But dental concerns as well keeps coming up because people, as they get older, need to take care of their dental care and often don't. So this is just a little bit about the history of Medicare. It started in 1945 where Truman introduced sort of a national insurance fund. But it was Dwight Eisenhower and Kennedy who really looked at senior citizens and their engaged voters, and that the fact that they are often uninsured older Americans. But it was Lyndon Johnson, as many of you know, who really signed into law Medicare. And Part A, still to this day, is hospital coverage. Part B, to this day, is still medical insurance. Doctors, anything outside the hospital is all Part B. But it was the expansion of that through multiple presidents in the 70s through the early 90s that became Part C for choice. And these are coverages through private managed care companies. And these are becoming more and more popular. School districts, unions, people are moving towards advantage plans. And there's good news, there's confusing news, and in some cases, concerning news about these plans. But all healthcare has a little bit of the good and a little bit of the confusing. It was George W. Bush, though, who signed into law the Medicare prescription drug Part D plans. It's certainly going under a great transformation right now, vis-a-vis the Inflation Reduction Act. But that's where it started, was 2003 through 2006 with George W. Bush. So health insurance is really different for everyone. It's because there are so many options that are available when you're approaching 65. When people were working, they had maybe a few options. Maybe they had a health savings account plan, a high deductible. Maybe they had a couple of plans. And then next year, the company renegotiated a little bit and maybe the coverage changed a little bit. But you didn't have nearly as many options as you do in the Medicare world. So it's a little bit overwhelming and confusing for people who are first getting the taste of what healthcare individually might be like. But as part of this, it's really important to look at your current coverage, even if you're still working, even if you're working for a larger company. There are times when group insurance and retirement plans are absolutely excellent. And then when you go underneath the covers and you look at the cost for the copays, the deductibles, the out-of-pocket maximums, it surprises people. Um, the premiums may be zero, but the cost of these plans, if you do have any need for utilizing the healthcare, is sometimes a surprise to people and what it covers and what it doesn't. So I and my team will review your offerings for group coverage, for retirement coverage, and let's do a cost comparison. Let's look at your utilization. Let's evaluate the premium costs as an employee and possibly a different cost for your spouse. And then there's children that may be on the plan, and that could be a deciding factor until they age out. But are there substantial savings or not? That's ultimately what you want to look at, and that's what I will help you do. So it's a review of your utilization. If you're utilizing your plan a lot, you know what copays, deductibles, and out-of-pocket maximums are. If you're not utilizing the plan a lot, then looking at that and comparing it to Medicare, because you don't have a crystal ball, still gives you a sense of what the risk might be in the future. So, what is the impact? The impact is, do I stay with my current group plan or do I transition over to Medicare? And that's ultimately what everyone needs to think about as they get to 65 or retirement. Either one of those factors are important. But the insurance carriers change their plans on the Medicare side. In some cases, every year, in some cases, very little. It really, from year to year, things will change. But in some cases, they're very subtle. But sometimes it's by state and sometimes it's by county. There are 4,000 counties in this country, and they all have a different advantage plan, and or they could have 30 to 50 advantage plans. How does one decipher them? That's the challenge of this industry. That's why independent brokers are out there, is to help guide you. But in some cases, it varies by state. And those are the Medigap plans, the Med Supplement plans. So there is some standardization on some of these plans, but not all of them. But each year, from October 15th through December 7th, this is the time of the year when people evaluate their plans, they look at their health, they look at their budget, they call us, we help them, we guide them. In some cases, they stay the course. In some cases, they make a change. So original Medicare, oh, original Medicare, Part A. Part A, in most cases, are premium free. For those people who have worked for 10 years in the States, or their spouse has worked for 10 years or 40 quarters, Part A is premium free. Many people will just simply get Part A at 65. They've been told by their friends, their neighbors, their colleagues, their family that if you don't get Part A, you'll get penalized. Well, that's not true. but people feel safe in getting Part A when they're 65. Part B is another story, but Part A is the inpatient hospital care, skilled nursing, hospice. Um, and there's really no reason to defer. Some people just don't want to bother. But if one has a health savings account, an HSA, a high deductible plan at their company, and they want to continue to contribute, one should not get Part A because it's not permitted. So for people who I'm speaking to, who I'm trying to figure out what plan they have, one of the standard questions is, do you have an HSA at your company? People love their HSA. They like to continue to use that plan. But in some cases, it makes sense to actually get onto Medicare. So Part A, age 65, probably 75% of the people I talk to wind up getting Part A. Again, no penalty. Part B, on the other hand, is really where the challenge is and where a lot of discussions that we have with people come to bear. Because Part B is really based on a few things. First of all, Part B is not hospital, it's outpatient services. So it's all the doctors, the specialists, the diagnostic tests, the labs, the x-rays, the durable medical equipment, all that's Part B. Part B has a premium attached to it. And Part B premium is based on your income, either single or married, from 2 years prior. So I'll go over the chart in a moment, but if the income as a single person is above 103,000 or above 206,000 as a married couple, the premium goes up. Under those numbers, it's $174.70 a month. That's baseline. It'll either come out of your Social Security check or you'll get a quarterly invoice. So, but Part B, if the income is higher, the premium for Part B. So the delay of Part B or the discussion on Part B is critical because, yes, the government will take your money for Part B if you sign up, but there's no reason to have Part B if you are working for a company of larger than 20 employees. That's the key. But if you are unemployed, self-employed, or working for a company of less than 20 employees, you must get Medicare A and B. So that's a key piece. Again, unemployed, self-employed, or working for a company of under 20 employees, that is where Medicare Part A and B is required. And that's where some of the confusion is, but often people are working for larger companies and they can defer. Part A and Part B is 80% coverage. Okay, so 80% coverage means that there's still a remaining 20% uncovered by Medicare. There's also no prescription drugs in original Medicare. So those are two things to keep in mind. You need to fill some of that 20% gap, and you also need to have prescription drug coverage. What original Medicare does not cover, it doesn't cover long-term care or chronic care. It doesn't cover hearing aids. It doesn't cover routine dental, caregiving, acupuncture, eyeglasses, contacts. Original Medicare doesn't cover it, but the Advantage plans as marketed cover many of these things listed. And so that's really where some of the decision is in terms of people's wanting some of these extra benefits or wanting the flexibility of any doctor they want anywhere in the country. But original Medicare does not cover some of these things. So is Medicare automatic? Well, the truth is that Medicare is automatic if you are collecting Social Security of any type. If you're collecting Social Security before the age of 65, you will automatically get your Medicare card, and it will have Medicare Part A and Part B listed on that card. For people who are working, again, for a company of greater than 20 employees, you need to actually decline Part B, or else they will simply take out your Part B premium every single month. I have many, many stories to tell about people who have been paying their Part B premium and they didn't realize it and didn't need to. But if you're working for a company of larger than 20 employees, once again, you can defer Part B, but you're going to get your card and you can reject it. If you're not collecting Social Security, however, you need to be proactive. So very often I'll speak to somebody, I'll do a webinar, people will call me a year, 2 years later, and they'll say, I'm ready to retire. I've been working for a company of greater than 20 employees. Now what do I do? I've got Part A. Great. If you've got Part A, then now it's time to get Part B. Okay. Um, and as long as you're working for that company of greater than 20 employees, having delayed Part B, not an issue at all. If in fact you should have had Part B, that's where the penalty is. And the penalty is 10% of the premium per month forever. So we never like to hear of anyone getting a penalty. We want to talk to as many people as we can. And very often people are retiring years later and they call us years later because now they're ready. So if you do have Part A and you're retiring at, say, 68 years old, and you say, I'm ready for Part B, I'm ready to retire, there are two forms that need to be filled out, this being one of them. This is the form that says, I want Part B. Your Medicare number is on top. You've applied for Part A. You have a Medicare number. You sign this, and on the bottom, there's a remark section. In the remark section, we put for you, requesting Part B effective date of, let's call it July 1st. So what we will do as a company, and you can do it on your own, is we will fax these forms to the Social Security office. This way we have that return receipt requested on the fax that we sent. And all we ask is that you call to confirm that they received this document so that you can get your Part B effective whenever you would like. Very often people are giving notice and they're not looking to actually, they're losing their coverage, but they're getting a month or two of extra coverage. They don't need Part B or want to pay for Part B for a few months. That's where we say requesting a Part B effective date of whatever beginning of the month is appropriate for you. That is one form. The second form is just as straightforward. This is basically confirming that you have credible coverage through the company that you or your spouse work with. So it could be one person is turning 65 and the other person is not. As long as you are looking to get Part B, you need to fill out this form as well as the previous form. And it takes the benefits people or the HR people moments to fill out. And basically it's saying when your coverage began, when your employment began, and when the coverage is ending or not ending. So there are people who are working for companies where they're paying a big part of the bill and Medicare is cheaper and in many cases, better coverage. Not always, because some companies are very generous and paying a lot of money for that coverage. But in some cases, Medicare at 65 makes sense, but this is the way one gets it, as long as one fills out these two forms. So I talked a little bit about Part B. Part B has a premium, and Part B's premium is looking at your tax return from 2 years prior. So you can see, like I said, $103,000 or less, $206,000 or less. There's no income adjustment. The Part B basic number is $174.70. It inches up each year. If you're collecting Social Security, that money will come out of your Social Security check. If you're not collecting Social Security, it will be a quarterly invoice that you can convert to a monthly premium if you like. But you can see that as the income goes up, the cost for Part B goes up. You can also see that married filing separately is not a particularly advantageous component of Medicare Part B. That does happen every once in a while, and it's a tough thing to communicate. But again, these are the government putting this in place. You can see that there's a small adjustment for Part D as well, which is the prescription drug side. So this chart changes a little bit each year. You can see that there's 6 brackets. And the good news is that if in fact you have had high income from 2 years prior, and you are retiring now and your income is dropped, this form is called the life-changing event form. We have helped hundreds of people with this form. This form allows you to reduce your Part B and Part D income adjustment so that you can actually go to a lower bracket. If somebody's retiring in, let's call it July, and their income drops because they no longer are working at the company, maybe their income goes down a bracket for 2024, which is the year in which we're in. But in 2025, it's even lower and it reduces it in another bracket. You can fill out this form yet again and get the Part B and Part D premium reduced. This is incredibly effective. Financial planners and CPAs love the opportunity to provide this to their clients because it is truly a saver. When you look at some of these numbers here, it goes up very fast and the brackets are very tight. So this life-changing event form is really about looking at the current year's projection, an estimate of this year's income, so that you can actually, whether it be marriage or divorce or work stoppage, these are the categories up top that are the 8 categories that allow you to submit this form and have the Part B and Part D reduced. Enrollment periods. There are enrollment periods that people are confused about or need to pay attention to. The initial enrollment period is what people often talk about. This is the 3 months before they turn 65, the month of their birthday, and 3 months after their birthday. Well, this truly only applies to people who are unemployed, self-employed, or working for a company of less than 20 employees. That's what this applies to. But because people feel like this is so vitally important to their Medicare lives, many people will get Part A, but not Part B. I've covered that, and it always comes up. Do I need Part B? Well, this 7-month window is really for those who are in that category I've mentioned many times. That's the initial enrollment period. The annual enrollment period is that period of time where TV ads, radio ads, mail in your mailbox is being inundated. And people are encouraging Medicare enrollees who are currently on Medicare to make a change because plans change a little bit. Prescription drug plans change a little bit. It is a very, very busy time, but we have a staff to handle it. And it is very important for people to review their plans based on their health, their budget, their travel, and any other health concerns that they may have. So that's that period of time. It's for an effective date of January 1st. So this is the period of time that is most relevant to current enrollees. The open enrollment period is a very unique time of the year. This is when people who are signed up for a plan still have a last chance to make a change during January 1st to March 31st. If they're on an Advantage plan, they can switch to another Advantage plan. If they're on an Advantage plan, they can go to Original Medicare and a supplement. They can't go from Original Medicare back to an Advantage, but you have lots of options within this period that it's not marketed. And we help lots of clients, especially clients who we have through medical offices that we work with, because very often clients will come and patients will come into medical offices and say, what do you mean my doctor isn't covered under my plan? Well, there's still an option through March 31st. So we helped a lot of people during this period of time for various reasons. The special enrollment period. This is really for those of you who are retiring after 65. So you can retire at any time of the year. And the key is to have a smooth transition from your current coverage over to Medicare. And so again, whether it be 2-3 months of giving notice or 2-3 months of being in touch with our firm, it's really about making sure that you have a smooth transition. You have a special enrollment. You'll have coverage through the end of a given month. You'll start Medicare at the beginning of the next month. And so that's a special enrollment. It's called loss of employer coverage. But there's also other special enrollments. There are natural disasters enrollments. There's hurricanes, there's floods, there's fires. Different counties around the country have special enrollments. There's also enrollments for people who are coming in and out of a nursing home or rehab. There's also special enrollments for folks that are on what's called extra help, low income subsidy, Medicaid, going on and off Medicaid. There's a good number of special enrollments besides the employer one. So if somebody calls us during the year and they want to make a change, we'll work pretty hard to try and find them a special enrollment to make a change. But as I often say, there's no guarantee. So to keep this simple, there are really four choices, folks. The first choice, going on to Medicare, again, at 65, I'll say this, if you are working for a company and retired, right, but getting, let's call it COBRA, right, you want to get A and B, okay, but you actually have 8 months of COBRA that you can hold on to. But most people are spending a lot of money on COBRA. And so once in a while, maybe for a spouse or for a child, they'll stay on the COBRA plan. But many people will look at their employer group plan and maybe stay on it because they're still working. Many people will also look at their employer group plan and say, I'm paying too much. It's coming out of my paycheck. Can I save any money by going on to Medicare? This is where the benefit summary is critical. So when I'm looking at people's plans and my staff is helping, we're looking at the benefit summary of your current plan or the plan that you're being offered in retirement. It may be the same plan as you're having offered to you while you're under 65, but there are companies who change their plans post 65. Again, a higher level of risk for the company, especially companies that are self-insuring. So we look at the benefit plan, we'll look at Medicare as an option and see which is cost effective. I will tend to suggest staying with plans if there is a very close cost comparison. The reason is because one, the employer plan is pre-tax. The second reason is people are used to the plan, they're used to the coverage, they're used to the carriers and their doctors that are in the network, they're used to the prescription drugs, they're comfortable with it. On the other hand, the pricing and the out-of-network and the pricing for out-of-pocket maximums could be surprisingly high. So I always try to find out what is the premium you're paying for yourself, what is the premium you're paying for your spouse, and then let's look at Medicare. If the employer group plan is the right plan, I, of course, will strongly suggest that you stay with it because, last point, is that very often if you leave your employer group plan, you will not be able to get it back. So that's important. The second option is original Medicare. This is the 80-20 rule. 80% covered by Medicare, 20% becomes your responsibility. The reason why people like original Medicare is because you can go to any doctor you want anywhere in the country that takes Medicare. So for people who are perfectly healthy and they want to go to any doctor and they don't want any other type of plan, they can go on original Medicare and nothing else. They do need Part D, but no supplemental medical coverage. I think it's a little risky, but there are people who do go this route. But the risk is 20%. The issue is not MRIs or X-rays, it's hospitalization and surgery. There's no maximum when you're on original Medicare only. Then there's Med Advantage plans, highly marketed, in your mailbox, on TV. A lot of famous people are marketing this. There's certainly a movement towards Med Advantage and very large companies, unions included, school districts. And these are fine plans, but you have to understand them. There are HMOs, which means you have to be in the network. There are PPOs, which means you can go outside the network at a higher cost. They include the prescription drug plan, but like your current plan now, you have copays, you have deductibles, you have out-of-pocket maximums, just like your plans now. So for many people, this is very familiar. Some of the out-of-pocket maximums around the country could be $3,000. Depending on where you live, it could be $8,000. So that's some of the risks that people have to be aware of. The most expensive part of Advantage plans are hospitalization and surgery. My comment, depending on where you live in the country, a hospital stay, each hospital stay, or each surgery could cost between $1,000 and $2,000. But presumably you're saving money from option number 4, which I'll cover in a moment. Again, these plans include prescription drug plans, not the copays, but they include the Part D, but they also have these ancillary benefits. So they have dental, they have some eyeglass coverage, they have some over the counter, they have some acupuncture, they have some gym membership. These things, these benefits are very appealing, and carriers are very much promoting these as a way to entice people onto these plans. So I'm a fan of these for the right person, as long as they understand it. Again, we look at all the doctors that you have so that we can see which carriers accept all the plans. Then there's number 4. This is Med Supplement, really officially called Medigap. These are the plans like Original Medicare that you can go to any doctor that takes Medicare anywhere in the country, which is 95% of all doctors in America. So people love these plans, but they're more expensive. If you're in South Carolina, you're going to pay under $100. If you're in New York, you could pay near $300 for these types of plans. So there's a variety of Medigap plans. The good news about these plans, though, is that they are standardized, as I mentioned very early on. The standardization, there's plans F, there's plans G, there's plan N, there's a high deductible G plan, but they're the same nationally. So people can get their arms around it sometimes easier than they can Med Advantage plans, because there's all these changes, bells and whistles, copays, co-insurances. These Medigap plans are very straightforward. They have no extra benefits like dental, like eyeglasses, like acupuncture, like over the counter. They're straightforward, but there's, in many cases, it's peace of mind, but again, more expensive. There are certain states in the country where you can switch back and forth without any health questions. And there are certain states in the country that if you switched from an Advantage plan to a Medigap plan, you have to go through health questions. So again, in the initial conversation and the initial assessment and consultation that we do as a company, we want to know what your health risk model is, how conservative you are. And of course, it's about health and budget. So these plans, these are the 4 options that people have. When we look at our doctors, your doctors, we're going to go through this exercise based on where you live, and we're going to look at the different doctors, and we're going to see which carriers take all your doctors. And we have staff doing this every single day. It's really an important component of what we do, and it really helps people feel comfortable if they're leaning towards an Advantage plan, that their doctors are either priority doctors, or their doctors are all covered, or they need to move to another carrier. But this is a part of our process, and people can do it on their own, but this is the value add that we bring every day. So to sort of summarize a little bit, Med Supplement plans really are the simple, the most freedom. They're standard national coverage. They're easy to understand. They're really for the more affluent consumers where premiums often are not an issue. The coverages are by letters. Premium ranges 100 to 300. They're standard across all companies, but the carrier costs are different. So you could have the exact same plan N, and carriers could have a $50 to $75 difference in premium. And so cost matters. Sometimes awareness of the carrier makes a difference. Sometimes average price increases over a given decade make a difference. Customer service makes a difference. So there are other reasons why people choose some of the carriers. Sometimes it's a $5, $10 difference. Sometimes it's a $50, $60 difference. But you can go to any doctor anywhere in the country that takes Medicare. That's what's beautiful about it. Maximum flexibility, minimum friction when it comes to getting approvals and working through the Medicare system. But there's no drug coverage. So there's no drug coverage. You have to get a standalone prescription drug coverage. Now to Med Advantage summary. These are a bundle. It's a bundle of one carrier making a decision on what are they going to offer in a given year. These are also parts C and D. So for people who are on an Advantage plan, they're on A, B, C, and D. For people who are on a Medigap plan, they're on A, B, Medigap, and D. So again, I know it's confusing, but it's somewhat clear in that description, I think. But the maximum out of pocket on these Advantage plans, the highest is $8,850, but other states in other areas of the country could be as low as $3,000. But they generally offer additional benefits. These are some of the things that I learned at Medicarian, some of the changes that are being discussed. Dental is non-negotiable. I can tell you that. No one's pulling dental. Now, the level of dental may vary, but no one's pulling dental. Eyeglasses as well. The other thing that often comes up is over the counter. People really want over the counter. Now, all plans don't offer it, but these plans change yearly, and that's really where a lot of the open enrollment conversations are. But again, these are network-based plans. And so do some doctors or some facilities go in and out of network in a given year? Some do, yes. Some consolidation is going on in the industry, and they're forcing people onto certain carriers with certain Advantage plans. Tough decisions all across the board. But healthy boomers, healthy baby boomers without chronic conditions, in many cases are looking at these types of plans. Again, the 4 states that have no underwriting is New York, Connecticut, Massachusetts, and Maine. The other states, and again, if you're looking to be in those states, great. If you're looking to move from those states to another state, call so that you have something in place that you can feel good about when you leave those 4 states. And then Advantage plan model also includes these dual plans, these Medicare, Medicaid plans. So prescription drugs, I can't tell you how important this component of the work we do is every day. The changes that are going on in this industry of prescription drugs, I can spend a half an hour talking about. The Inflation Reduction Act is going to impact this. For some people on the phone who are on expensive medications, you might very well see some real changes that will be of greatly advantageous to you. There are some other medications that may go up slightly, but each year the carriers are looking at their profitability on these plans, and we'll see how 2025 pans out. We won't know very much until late summer. We get official information October 1st, and we will be ready to handle all of the needs that our clients have. So on these Med Advantage plans, there's no cost for the prescription drug piece. Okay, but you pay the copay still, but there's no cost for that plan. On the standalone plans, you actually have a premium. And so that premium, there are premiums that are $0. There are premiums that are $3.70. There are premiums that are $118. So depending on the medications that someone has, it can vary greatly. And again, that's the work we do. The annual deductible for 2023 was $505, $545 for 2024. This is only in place for those people who are on brand named medications, not generics. So very often when people are on brand name medications, the first month or two, they're hit with this deductible and they're surprised, they're shocked. But after that, the price goes down. There are 4 stages of pricing in Part D. There's the deductible phase, there's the after deductible phase, there's what used to be called the donut hole, which is now called the coverage gap, and then there's what's called catastrophic. Due to the Inflation Reduction Act, there has been a cap placed on brand name medications. That, depending on whether it's a combination of brand and generic, it's either $3,300 max or $8,000 max. $3,300 is the max for brand name medications. In 2025, it's going down to $2,000. So for many people, that's a real game changer. There are discount cards. There are preferred pharmacies. There are standard pharmacies, and there's mail order. A preferred pharmacy is going to give you a lower price than a standard pharmacy. People are always surprised to know the difference in price, and it could be dramatic. There's Good RX for some medications that we help research. There's other discount cards called Single Care. There's also pharmaceutical grants that we are often able to direct people to, or often early in the year is better when the grant money is available. But there are ways to save money on expensive medications, and we try our best to guide people in that direction. It's usually through the drug company. Sometimes it's based on income, and sometimes it's just based on need. And so all of these things are part of what's really an important component of the work we do. So again, I'm sorry for that red line on the screen. Don't know how that happened. So this is just an example of the different pricing that can occur for just, again, these are the same drugs, right? The left side of the screen, the right side of the screen. You can see that we're picking pharmacies, and we're picking, there's deductibles, and then there's premiums. So you can see there's a vast difference between premium. There's a vast difference between costs for the prescription drugs themselves. And then mail order sometimes is better and sometimes is not. So this is the work that we do. We use a very commonly used site called Medicare.gov. We save all of these in every client's file so that if they want to see it and understand it more closely and the details behind this, we're certainly able to provide that. One of the big changes that occurred over the last few years is the reduction of cost of insulin. The amount of money being spent on insulin and diabetes prevention is a huge part of the economy for healthcare. And so it was important to lower the cost for most of the insulin medications to $35. It is now available in every state with almost every carrier. And so this is something that's really made a difference for many people. The cost for insulin was particularly high, and now it's gone down, and that's been very nice. Dental coverage, again, often asked about. 7 things to know about dental coverage. These Advantage plans do not have the same dental coverage. The good news about them is that there's no waiting periods. Some of these dental plans that are out there have a waiting period that you can't get extensive work done. There's no waiting period on these Advantage plans. Standalone plans, which could cost between $35 and $85 per month, can cover you up to $10,000 worth of coverage, but the policies vary widely on details and the cost. You know, it's okay to ask your dentist for a cash discount. It's okay to ask your dentist to see if they can help you control your expenses, maybe from one year to the next. If you have any kind of coverage, you put some into one year and then roll it into the next year and take advantage of the following year's same coverage that you have from year to year. But anything beyond preventative, cleanings, x-rays, fillings, I can tell you from a lot of experience, personally and professionally, that you need to expect to come out of pocket. Again, a lot of changes in dental coverage being considered. It's not a part of Medicare Part B yet. It might be someday, but it isn't yet. But after leaving a job, you might be able to keep your dental through COBRA. Many people do that. We suggest considering doing that. Again, depending on how often you use the coverage and whether your dentist takes the coverage or maybe they submit the bill to your carrier. All those things are part of the conversation. We have a staff person, Carrie, who's devoted to the dental coverage, who can certainly help you through that as well. But for people who do have that HSA that I talked about quite a while ago, that HSA money can certainly be used for dental coverage. And people who have accumulated HSA, they are grateful for that, and they also can use it for dental. You know, when it comes to dental, reasons people aren't visiting the dentist more frequently is cost. The cost of the dental work, because so much of it is out of pocket, is why 47% of people over the age of 65 do not have dental coverage. And that's a staggering number. And again, any dentist will share that having your dental work done on a regular basis is key to your long-term health. But people say they're going to go, 77% of the people say they're going to go visit a dentist, but only 37% of the people do. So it's expensive. It's really a fee-for-service model. A lot of it is out of pocket. 1 in 5 Medicare beneficiaries spent more than $1,000 out of pocket. 11% spent $2,000. Top reason people don't visit the dentist is cost, including high-income earners. You can get an in-house discount plan from your dentist. It's usually about $200-300 a year. You're paying up front. You're basically getting cleanings, x-rays, and fillings, and then supposedly you're getting a discount for the rest of the year. What is it being discounted off of? The truth is that dental costs have a range. It's not like medical costs where a Medicare approved charge is a pretty set number. In dental work, it is not that standard. So when it comes to the kinds of services that are provided, preventative are the standard cleanings, x-rays, etc. Basic is a little bit more simple extractions, but the major components of bridges and crowns and root canals, all that is under comprehensive or major work. And that's where often these carriers are asking you to pay 50% of what the actual cost is. So this is just an example of a particular carrier that we know. It's actually connected to MetLife, and we are helping a lot of people with this, but there are many carriers we help people with. We know of about a dozen. We probably work with probably half of that we have had great success with and clients have had great satisfaction with. You can see that for $1,500, you can get of coverage for the year. It's $57 all the way up to $82 for $5,000. There's also a new $10,000 coverage plan that's available. So the future, the federal government is looking to pass some legislation around it, but it has not been able to get through the House and Senate. It was a bill proposed and it didn't pass. But if there was a dental benefit, it would cost about $238 billion over the first 10 years. And it will increase premiums by about $17 for Part B per month per person. So there's a chief dental officer in the government. This is a serious issue. The government knows it. Advantage plans have addressed it. Original Medicare has not. So just a little bit on dual special needs. These are plans that are both Medicare and Medicaid. These are people who are dual eligible, and they actually get extra benefits. These people have no copays on prescription drugs. They get extra dental, extra eyeglasses. They get hearing benefits. They get over the counter. But this is people who are on Medicaid, not the subsidy before they were 65, but they've gone through all of the legal paperwork to get Medicaid. And then they also have Medicare. The carriers are very much focused in on these dual enrollees and really trying to enhance the coverages that are being offered. Each year these change, but they are good benefits. And for people who qualify, you can change more than once a year. So these do have special enrollments. But people are really grateful when they're in this particular situation to be able to get these extra benefits from these carriers. So things like over-the-counter, healthy foods, pet supplies, yes, transportation, utilities, some rent, These are the kinds of things that the dual special plans offer. But again, you have to have Medicaid and Medicare to have these. So we're getting towards the end here, and I really hope that this has been valuable. I love doing them. Again, I wish it was live. Um, you know, we are recording this for the future for other people who may not have been able to attend. We've got close to 100 on. And again, anyone who wants to talk to myself, Jackie, or my staff, please, I think Michelle has put in our phone number and our email address, info@emeraldmedicare.com. Please reach out. We're happy to help. But some of the changes that have occurred in 2024, the Part B premium went up. It was $164.90 a month. Now it's $174.70 a month. So that's a bit of an increase. Yes, Social Security wages went up, but certainly Part B premium went up. The Part B deductible, for those of you who are on Medigap plans or are considering it, last year it was $226. This year it went up to $240. The Part D deductible went up from $505 to $545. So again, these are increases that are helping with what's called the loss ratio for the carriers. So they're looking at their profitability, and you're looking at what's best for you. The out-of-pocket maximum, the highest in the country, is $88.50, but by no means is that the way it is all across the country. Certainly in the Northeast, a lot of the plans are that number. But recognize, as people who took the time tonight to listen to me here, recognize the importance of knowing your plan's potential costs, right? There's no crystal ball, it's true, but you also can understand the plans that you're looking to get. And then in some cases, you can easily change each year. And in some cases, you need to understand what the possibility of changing is, and or when you leave some of those states that I mentioned, on what you need to maybe consider before you leave. But there's also the importance in the integration of healthcare costs and financial planning. I work with a huge number of financial planners, and they do understand more and more as I educate them, and I've educated and speak in front of them all the time, is that they know that people need to get good advice. Financial planners don't have this expertise, and they want to be able to make available to their clients a resource. But the healthcare costs are important, whether it be just a Part B premium and an Advantage plan, or a Part B and a Medigap, and then prescription drugs. Advocate and appeal. It is a true statistic, and I've heard it confirmed, is that of the people who, 80% of the people don't appeal, don't advocate on things that maybe were denied, declined, prescription drugs, et cetera, medical costs. Of the people that advocate and appeal, 80% win. And so it's really important to realize that whether it's you or a family member or a caregiver, it's important to advocate and have someone or yourself to look at and realize that you don't pay every bill you receive, because sometimes it has to go through Medicare and the supplemental coverage before you go ahead and pay that bill. You're not going to get that money back. Make sure you know what's being billed for before you actually pay for the service. Seek objective education. I am totally independent. My staff is. We work with 17 carriers. We're going to do what's in your best interest 100% of the time. And that is what our reputation is and what we're absolutely proud of. AEP, open enrollment, October 15th through December 7th. There are some of you I know who are on Medicare right now and are just looking to reinforce your knowledge. So remember that October 15th through December 7th. My belief is that people aren't going to reach out until after the election. But reach out early so we can, talk, run your meds, see what's going on, and help guide you so that everyone's not in a last minute crunch. But there are decisions for Medicare at age 65, even as simple as whether I should get Part A, and then retirement. Again, for us, it's frequently asked questions. For you, it's a little bit overwhelming. And you need to know that there's someone who's got your back, and you're in good hands. You really are in good hands with Emerald Medicare. Look at your doctors and your medications. Okay. At the end of the day, you want your doctors in most cases. You want to know what your medications are going to cost. We can help you through that. And that's what a broker should do, is to be able to help you through this process, knowing that you can feel comfortable in the doctors you use and the cost of your medications. But the Advantage plans, the Medigap plans, or your retiree package, whatever it may be, understand them. Understand what your options are, your choices are, because at the end of the day, you have to make a decision. Some cases you can change from year to year. In some cases, you're going to probably stick with those types of plans for a long time. Medicaid and Medicare, these are the dual plans that are available to those who are on both. And I say identify a trusted resource. I'm really proud of what we are as a company and what we've been able to provide to so many folks. If any one of you know of a place that I can speak in front of a group of people, whether it be an association or whether it be a senior group of any type, over 55 community, people who are care managers, social workers, I'm happy to do so. So again, this is my wonderful staff, minus one. But between Jackie and myself and the rest of my staff, I want to thank you for listening. I hope you've been able to reach out to Michelle and ask some questions. It looks like there has been a good sense of activity on the chat, but please do reach out, set up an appointment to talk to one of us. We'll help you through it. And again, thank you for participating, and I hope it's been valuable. Thank you all so very much. Have a great day and a great season. Thank you.